Hi, everyone. I'm Dr. Rob for Jefferson Health Northeast, and this is Your Health Matters. And it's a special edition today. I'm here with two leaders, and not only in our community, but also in the city and our region. Dr. Jerry Wadrow. Dr. Wadrow is Regional Director of Emergency Medical Services in our area, as well as Chief of Emergency Medicine at Jefferson Health Northeast, and also Dr. Reed Goosh, who he is the director of a new and amazing program that's bringing big city medicine right here to the Northeast and to Bucks County, and it's the advanced thrombectomy stroke treatment. And we're going to get into that because what does that mean? Well, you know what? It can mean the difference of your loved one being able to be who they are, being able to think normally, being able to move normally, being able to enjoy their life like they did before this potential stroke that they're having. That's how important this is, because this type of treatment can keep your loved one in good shape and being able to live their life more fully. Because I'm sure a lot of you have heard or seen people who have had strokes. It's devastating, or it can be, not only to the person with the stroke, but also to their loved one and friends. It changes so much. So doctors, I want to thank you both for being here today. You know, the coordination, how you both have worked together in your individual departments to help our community has been fantastic. And, you know, I just wanted to start off with, you know, what exactly is a stroke and why is it such a problem? So I thought maybe Dr. Goosh, maybe you'll start, and then Dr. Wadrow, because you're both approaching it as a team.
Yeah, so the vast majority of strokes that we see are ischemic strokes, meaning a blockage of a blood vessel in the brain. This can happen, I mean, it usually presents suddenly with people experiencing either difficulty with speech or vision changes or focal weakness, such as a face droop or weakness in an arm or leg or both. But the stroke is an emergency. So person needs to call 911, they come to the emergency room, they're evaluated by Dr. Wadrow and his team. And then the first line treatment after getting a CT scan is usually a clot busting agent, or TPA. However, we also get vessel imaging to try to see if we can visualize a blocked vessel, again, in either the neck or up in the brain. If we're able to kind of, you know, in the right patient, we can also emergently take that person to an angiography suite where we thread a catheter either from the radial artery in the wrist or from the femoral artery as it comes up from the leg, and we can actually go up into the brain with these tiny catheters and either suck out the clot or actually deploy a stent and pull out a clot and reverse a stroke or prevent a more significant stroke from occurring. So this is called a mechanical thrombectomy, and it's something that we've been doing for many years now. And the reason that this is news is right now, if you present with a stroke at Jefferson Torresdale or Jefferson Northeast, and you're deemed a candidate for a mechanical thrombectomy, you are transferred to Center City, Philadelphia. But starting in October, we will plan to be doing that procedure at Jefferson Torresdale at a new biplane suite.
So this is amazing what you're bringing in. You know, Dr. Wadrow, your first line, right? People come to your emergency department for you and your team with these symptoms of a stroke, and your team just works them up so quickly. So tell us a little bit about how you prepared your team to get ready for a patient coming in who may have signs or symptoms of a stroke. Kind of walk us through that, and then how you link up with Dr. Goosh and his team, to get them treated.
It's a good question, Dr. Rob. And I think, you know, the key to all of these conversations is awareness. And, you know, our message always, whether it's to the patients or to their families, is being aware of the signs and symptoms of a stroke. It can be very subtle in the beginning. And I think most people think of, you know, the paralysis of the face, the lack of the ability to move an arm or a leg, but sometimes it could be subtle. It could be some dizziness, or it could be a slight visual change and then progress. So we really want to be vigilant about education. I will tell you, we really message out that if somebody's having signs or symptoms of a stroke, we want them to call 911. It is better to come in the EMS service, the EMTs and paramedics in the field, for two reasons. One is they can do rapid assessments to determine the potential severity of the stroke. And also they know which facilities offer different levels of stroke care. That can be primary stroke centers, comprehensive stroke centers, or as Torresdale is moving toward becoming a thrombectomy case stroke center. And it's critical if you how Jefferson has been building out stroke care in our region. It's about a year ago that we started the mobile stroke unit. We were there as we were unveiling that at Ben Salem EMS. And over the past year, we have had hundreds of EMS responses with the mobile stroke unit. And we've given the clot busting drug TPA to multiple patients. This is the natural extension of that, where university level care is being brought to our neighborhood. And patients, instead of having to be transferred, could have the mobile stroke unit or another EMS agency get to them, identify a stroke, tell us ahead of time, bring them into us. We have the ability at all three of our campuses to do advanced imaging in the emergency department. And then with that advanced imaging, talk to Dr. Gooch, members of his team, so that they can make an informed decision about what's the right treatment to perform. That could include the clot busting drug or something like a mechanical thrombectomy, as Dr. Gooch will talk about.
And Dr. Wadrow, you mentioned about the community and EMS. You also have something very unusual, getting people ready for Dr. Gooch. And don't you have a mobile stroke unit that you work with? It's this huge, amazing van with all this equipment.
Yeah, that's what I was saying. It's been about a year since the mobile stroke unit was live, and we really seen the value of that both for education as well as for treatment. And we've had many patients treated by it. As you know, Dr. Rosenwasser, who runs the Jefferson Hospital for Neuroscience in Center City, and has been pivotal in us getting both the mobile stroke unit in this area, as well as initiating our thrombectomy lab here at the Northeast as well. So we're actually very excited because we have both of these strategies, both the pre-hospital strategy as well as the in-hospital strategy to treat patients who are having an acute stroke in a very rapid fashion, but with the highest level of care that you can get anywhere.
Thank you, Dr. Wadrow. And Dr. Gooch, how important is time? They come in, Dr. Wadrow's emergency department with him and his team from EMS. How important is it for people to know the symptoms, as Dr. Wadrow mentioned, even the subtle symptoms, and get this taken care of quickly?
Yeah, I mean, the short answer is time is extremely important, but it's a little bit different for everyone in that really the time window for intervention is can be longer in some people than others. Realistically, for us, it's usually about 24 hours is the time window before it's less likely for a person to benefit from a mechanical thrombectomy. But in every case, the sooner the better. So it's very important for people in the community, for patients to understand that they should not ignore symptoms. And certainly there are plenty of patients who come into the emergency room with symptoms or complaints that end up not being a stroke, or they don't go down that pathway. But that is fine compared to the patient that comes in that has ignored symptoms for several days, and then is found that the stroke is already completed, so to speak. And in those cases, it's much more difficult to provide any sort of any care that can kind of immediately help them.
It's interesting. Dr. Wadrow, Dr. Gooch and I were talking a little while ago about you can't always go by the symptoms. Sometimes it can be very mild, we might think, but actually could be a very significant stroke evolving. And Dr. Wadrow, you mentioned about dizziness. Should a person in their 30s be worried, or 20s, or is this more someone above 50 or 60? Because a lot of people think, it's just dizziness. Like, what have you seen, and what should people know about that?
Well, as we've talked about in other discussions and other episodes where we've talked about heart disease and and so forth. Stroke, like other cardiovascular diseases, does have risk factors, and there's no question that advanced age, smoking, hypertension, diabetes, having elevated cholesterol or hyperlipidemia, those are all risk factors for stroke. In addition to that, certain diseases that increase the prevalence of giving you what's called embolic disease or clots, such as atrial fibrillation as well, are risks. So I think that although we've all seen young patients have strokes as well as obviously older patients, what we generally would say is around dizziness, which can be a very subtle presentation. Certainly, if you are of advanced age or have multiple medical problems, seeking care for evaluation of that makes sense. The other piece of that is, dizziness such as mild vertigo. Right? Many of us have had vertigo at some time in our life, the sense that you or your environment are spinning or rotating. That's one thing, but when people are off balance, when people note that the dizziness makes them feel like they're going to pass out, or if they have other associated neurologic symptoms, that could be vision change, speech change, numbness in a part of their body, that is clearly something that requires further evaluation and workup. And they should call 911 and they should come to the hospital for evaluation.
And Dr. Roger, you mentioned, you train, you're the regional director of EMS. So all those that you train, and just people be reassured, they all know about this, right? You do drills with them, you educate them. So if they call, those people responding will immediately talk to you or your team and let you know those symptoms and intervene if necessary, right?
Right. So the EMS providers are trained not only in how to make a rapid assessment for stroke, it actually starts at the dispatch center. So our dispatchers, when we call 911, will do a mini triage to determine if you're having signs or symptoms of a stroke. They use that to determine which entity or which agency should be dispatched. And then on top of that, EMS providers get there. They can do a more thorough assessment, but also, as importantly, rule out other things. So sometimes people can have a stroke, but it was actually a low blood sugar, or it could be intoxication, or it could be some other kind of manifestation like after a seizure. So the EMS practitioners can get there, look at the situation, make an assessment to determine, does this patient actually have a stroke? And if they do, how severe is it? What we're asking them to do now, something we never used to ask them before, is help to make an informed decision with that patient around the right destination. So, primary stroke centers offer high quality care, but if the person needs a mechanical thrombectomy, they need to be transferred out. Our EMS colleagues, we're educating them, just like we're educating the public, to say, if you have a patient who has a more severe stroke, and we actually have scales that we ask them to go through to come up with a score. And if that score is elevated, we say, if you can, consider transporting to a thrombectomy capable or comprehensive. In the very near future, we have the Jefferson Torresdale campus will be one of those thrombectomy capable receiving centers. EMS will know that and will bring people to this facility with the knowledge they can get that advanced care.
That's great. And, Dr. Gooch, maybe we can just back up 1 second. So thrombectomy, what is the difference? I just want everyone to realize there's certain types of strokes. So what exactly does that mean? And does that mean anybody with a stroke can have that, or are there different types? And you and Dr. Wadrow and their team determine right away what's the best treatment?
So the mechanical thrombectomy is only going to be performed on an ischemic stroke, number one. So as opposed to a hemorrhagic stroke. So a hemorrhagic stroke is a bleed in the brain. That kind of sets the patient down a totally different pathway. Now, if there's if a person has stroke-like symptoms and they have a CT scan which shows that there is no bleed, then it's assumed that they are having an ischemic stroke or lack of blood flow from presumed a blocked artery. Now, the arteries, it goes from, the carotid artery, let's say, goes up into the brain, divides, and the arteries get smaller and smaller. There are a number of, the imaging is able to visualize an actual occlusion of what we call large vessel or even medium size vessels. So if someone has an LVO or a large vessel occlusion, that's traditionally a carotid or a middle cerebral artery in the brain is blocked. If we can see that on a CT angiogram, which again, a CT angiogram is a CT scan that's obtained by giving dye through the vein. So that's a non-invasive imaging that can be done in about a minute or so. We see that if we see the blocked vessel, then we can go after it. And by going after it is, that's when we perform a mechanical thrombectomy. And that's what the patient is brought to a biplane suite, which a biplane suite is basically an X-ray suite where the patient is positioned on a table that we're able to move around and have two X-ray machines kind of hovering over the patient. We generally do these procedures with the help of an anesthesiologist, but without general anesthesia. So an anesthesiologist is there to sedate the patient so that they're comfortable, but usually no breathing tube is placed. And that's also because it's not painful what we're doing. And also we want to move. We don't want to waste time intubating a patient if we don't have to. The procedure ideally takes about 30 minutes or so to do. What will happen is, about 80% of the time or so, we're able to open everything up and we physically pull out a clot. I mean, we have pictures, you see the clot, you're looking at it. And then the blood flow is restored. Sometimes a person gets better immediately, but even if a person does not get better immediately, the patients that have the blood vessels opened and the blood is restored, they do better over time. Sometimes it's a few days. The recovery can take months, but generally speaking, the patients who have the blood vessels opened do better than the patients who do not.
I mean, this is just fantastic what you both are doing and what you bring here. You know, Jefferson Northeast is kind of unique because we serve such a broad geographic area. And Dr. Wacho, you mentioned that it's available at any of our campuses. What would happen, say they go to our Frankfurt campus or our Bucks campus? Does your team then transport them to Torresdale? How does that work so everyone is aware?
Yeah, it's a great question. You know, as with many things in emergency medicine, we follow a pathway. So we are able to do the advanced imaging at any of our campuses in the Northeast, Torresdale and Frankfurt. But at Frankfurt and Bucks campus, if we identify a patient who has a suspected large vessel occlusion, after that imaging, we talk to Dr. Gooch or one of his team members, make a decision. And if the decision is that they would need the thrombectomy procedure, we would then expedite their transport to Torresdale, where they could go directly to the lab and in the biplane room, then get that intervention done. So essentially, the patient's coming here as that doctor is coming here, they have the team here, and then they meet the patient and take them to the biplane room. That's our model. We do the same thing for trauma. We do the same thing for people having heart attacks. And this is just another example where you can leverage having the three emergency departments act as one. And our goal is always to provide the same high quality care for people having these acute emergencies, whether traumatic or medical, like in this case.
You know, Dr. Gooch, with what you're doing, you know, you've seen dramatic changes in people. How new is this procedure? And, you know, not everyone can do what you and your team are doing. It's pretty unique in this area, isn't it?
Yeah, I mean, it's been over the last several years. I mean, I've been in practice now for just over 3 years. And, you know, before that, I was in Albany, New York, and I was a junior resident when we did the first mechanical thrombectomy using the technology we have now. I mean, people have been trying to do this for a long time, probably since the 90s, but it's really, it's only been the last few years that we've had the technology to do it well and the evidence to back that up. So it's, you know, it's what is going on here. You know, us bringing this technology to Torresdale is occurring all over the country. We're a little bit behind the cardiologists in that sense, where people, you know, initially you could only get a coronary stent emergently at the university hospital, and then that kind of spread out into the community over time. And we're kind of, it's the same progression. It's very similar, actually.
You know, if you don't mind, we had a couple of questions because some people knew about this in thrombectomy. So one of the questions was they heard that we have sometimes Tele-neurology, where you have a neurologist on, and they ask, is that involved, Dr. Wadrow, when they're in your emergency department, the neurologist gets on and looks at the patient? How does that work?
Yep.
Questions.
That's a great question. So when we activate a stroke alert in the emergency department, they're evaluated by the emergency medicine team. There's rapid imaging that's obtained, as Dr. Gooch was saying, to rule out hemorrhage in the brain. Once we have that, there's a rapid decision making around should this patient, would they be eligible to get the clot busting drug, the TPA. In that same time, we bring on a tele-neurology physician from Jefferson. We call it the robot. We bring the robot to the room. And then there's a rapid assessment, a discussion between the two clinicians, and then a discussion with the patient and their family. And then we try to make it through shared decision-making, is this the right patient to get that drug at that time? In this model, not only will we be able to offer that, but there'll be a secondary opportunity to have a conversation. Would this patient be appropriate for thrombectomy? And that will be dependent upon the imaging results as well as the severity of their symptoms. So the telemedicine component, and as that could be another show, how telemedicine in this COVID environment has really changed, and we're using it for so many things. I will tell you that using telemedicine for neurology has been going strong for about close to 10 years now, and is a really, really great tool because it allows you to leverage a single neurologist, a stroke neurologist, to cover multiple hospitals. So I'm sure Dr. Gooch can tell you, I have many a night, 3, 4 in the morning, woken him up to have him help me assess a stroke patient and make a shared decision around giving TPA. And that's what happens. And Dr. Gooch is not only covering my hospital, but probably 10 or 15 others at the same time.
That brings me to the follow-up question. Dr. Gooch, using tele-neurology, how difficult is it for you as a physician to size up the situation? Is it harder doing it that way, or is it open new frontiers and better patient care?
No, it's incredible. The technology is scary how good it is. Okay, because just with a phone, you don't need to have Wi-Fi. You just have normal cell service these days, and you can see crystal clear what the patient looks like. It's really like you're at the bedside. You can zoom in. You can see. On your phone, you can zoom in. You can see someone's pupils. It's probably more startling for some of the patients. I'm used to it by now. Some patients get a little bit weirded out. They kind of don't understand what's going on. There's actually a comedian that had a bit about it where he thought he was in the future. But it works very well. And it also works in just talking with the in the ER, where just talk to the ER docs. Like you feel like more a part of the team, I think. It's one way to put it. Would you agree, Dr. Wadrow?
No question about it. I think that the nice part about it is just that, is you wheel the device in, you tell the patients, and then, Dr. Gooch is on. I'm like, hey, Reed, this is Mrs. Smith, and she's 55, and here's her symptoms. And
we're normal with it. The patients sometimes are a little.
The patients are blown away. They're like, how is this happening? And then they see the results of it. And again, it's a force multiplier, is what I always say about it. It allows you to have a single provider who back in the day would have had to get in their drive to a hospital. Now they're able to be a force multiplier and across multiple institutions. And that's really the value add, is you get that expertise. And that's why we're leveraging it, and have for years in the Northeast, to not only treat stroke patients, whether they get a clot busting drug or not, but now in this case, we'll leverage it even further to determine who's going to get thrombectomy, who's going to get transferred to the Torresdale campus. It's really miraculous how well it works. It's mind-blowing and so beneficial to the patient, but also beneficial to the providers and the communities we serve.
And I think all of you out there, what Jefferson Northeast has brought, and these doctors and their team, is really the best of what is available right now in the country. one of the leaders, and it can really help your family and your loved one tremendously. I mean, Dr. Wadrow, Dr. Gooch, I mean, you've seen over the years, Dr. Wadrow, you've been practicing for a while. You've seen the devastating effects of stroke, and you didn't have these tools earlier on in the emergency department, but now I'm sure you've seen. And what does it mean for families? You're right there on the front lines.
Yeah, I mean, you know, when I was a resident physician back at, to Reed's point in the mid '90s, you know, we took that stroke patient, put them in a bed, and then they, you know, they got admitted to the hospital. There was no urgency, there was no intervention, there was no treatment, and to look, you know, the 180 that's happened now, these patients are treated with the same level of priority as a heart attack or a trauma patient. That I think is the value, that we're leveraging models of care that we have proven, time-tested models of care, and applying it to stroke. And I think the value of that has really been born. And again, the mechanical thrombectomy piece of this, what's so nice about that is not only can you start the clot busting drug, but then they can go on to get that thrombectomy. So it actually is allows you to leverage, again, that treatment model, expand upon it. So it's not like it's, you know, we're a one-trick pony. We're offering multiple opportunities to treat patients, and the ability to do that, when you look not that long ago, less than 25 years ago, we really did almost nothing except for supportive care and trying to get the right rehab together to get that patient to be as functional as they could. Now we're treating the source, and that is a game changer.
And thanks, Dr. Wadrow. And Dr. Gooch, so one of the questions a viewer said, what got you into this? Because they wanted to know, like, how does someone become such a specialist in this type of technology? What was your interest, was their question, to be able to do this?
You're asking me, right? I'm sorry, I missed the beginning. So my dad was a neurologist, actually. So I grew up aware of neurology, and then I went to medical school and got involved in surgery, and then neurology and surgery, neurosurgery. And then from there, kind of, you know, it's all randomness of, you know, the people that I was around in my training, and kind of, and what I was drawn to in the patients population that I saw was vascular neurosurgery, I should say. And then one thing led to another, and then I became a vascular neurosurgeon, and then came to Jefferson, where Dr. Rosenwasser has built this amazing network, and it's all led to this. I mean, I had never done telemedicine until I got a job at Jefferson. I didn't know I was gonna be doing that, and but the issue is if you're a vascular neurosurgeon and you treat problems of the brain and vasculature of the brain, stroke is the monster. I mean, it's so prevalent, and so we've become experts at it.
You know, I think everyone out there, I don't know if you know, but Dr. Robert Rosenwasser is one of the greats in our country in this field, and Jefferson is one of the leaders in our whole country in this field, you know, with stroke and the neurosurgical advances that they've made. And now it's available, or will be available very shortly, right here in your own backyard. So you can be assured that you or your loved ones are getting the best possible care that you can get. And I mean, this is phenomenal. So the biggest thing is, you know, Dr. Wadrow, someone wrote down, when they call 911 and they have symptoms, will the squad know to take it directly to this best care, or do they take it to the closest hospital, was their question?
It's a great question. So the EMS services, the EMS providers have protocols that are created by the Commonwealth of Pennsylvania. And in those protocols, it actually gives a very straightforward decision matrix. It has to do with the severity of the stroke, because as we were talking about, Dr. Gooch mentioned the large vessel occlusion. We call it an LVO for short. Patients with an LVO typically have more severe symptoms. And in that setting, the EMS provider is not only screening for a stroke, then ruling out possible reversible causes. We talked about low blood sugar. And then screening for the severity. And if they screen a more severe stroke, if they're able to get to a thrombectomy capable facility, like Torresdale will be in the very near future, they would preferentially transport to that facility. Patients obviously should advocate for themselves as well, right? So a patient can ask an EMS agency, hey, I would like to go to this particular facility. And again, if it's very far and distant, the EMS agency can't do that. But if it's in a close proximity, they often will. I will tell you that our EMS providers are incredibly good at this triage algorithm. They do it for stroke, they do it for heart attack, they do it for trauma. And this is just another nuanced way with, we do training for our EMS providers, and that happens both at the agency level as well as the regional level. That training, one of those pieces is helping to make these decisions. What is the right destination for the patient? So yes, if they call 911, starts with the dispatch center, goes through to the EMS providers, they do some assessment to get them to the right destination.
Thank you, Dr. Wadjoe. And, you know, Dr. Gooch, I want to thank you also for coming up here to the Northeast and, you know, really helping Northeast Philadelphia area and also Bucks County. Any additional information that you would like to share with our viewers right now about your program, and when is the start date?
The start date is tentatively for, so first of all, I should say my pleasure. It's an honor. The start date is tentatively scheduled for October 12th. So obviously, I mean, as you can imagine, there's a lot of moving parts. Our original start date was March 2020, which is, you know, a joke now of everything we dealt with in March of 2020. But yeah, next month is when we plan to get going.
This is fantastic. And for everyone out there, I mean, we're seeing two of the leaders in the coordination between EMS and the emergency department and Dr. Gooch it's not just two people talking together. There are a lot of planning meetings that went by and went forward. And basically it's all about you and speeding the care for you and your loved ones. So Dr. Wadjoe, all the work that you've done, Dr. Gooch, all the work that you've done, and, you know, thank you both for looking after the community, because that's basically what you're doing. You're looking after everyone. And you live and work in this community too. So we want to thank you so much for being here at Jefferson Health and for all your efforts. And for anyone out there, you know, if you would like more information, please go to jeffersonhealth.org or jeffersonhealth.edu, and you can get more information or just call our main number, 215-612-4000, and they can hook you up to the right place. And Dr. Gooch, your question was, do you also see patients just for general neurologic concerns?
Yes, we see patients at the Jefferson Torresdale office, both in general neurosurgery and vascular neurosurgery.
All right, there you go. And the primary care docs, your family docs, and general, you know, physician assistant, nurse practitioners will all know about this great service here at Jefferson Health. So if we can help you, we're here. So I want to thank you all for joining us for Your Health Matters. And Dr. Wadjoe, Dr. Gooch, thank you so much for everything you're doing. And hopefully everyone will be well and we'll have a good autumn season. And good luck with this program.
Thank
Thanks,
you for
Dr.
having us.
Rob.
Take care, guys.